Okay. Good evening, friends, to the 7th part of the series of the State of Gender Equality, #GenderGaps, brought to you by Gender Impact Studies Center at the Impact and Policy Research Institute, Delhi Post News, Gender Center for Research and Innovation, and Filmmakers International. These are collaborators with IMPRI. Today we have, Dr. Sanghamitra as Acharya, who is a professor in the Center of Social Medicine and Community Health, School of Social Sciences, Jawaharlal University, New Delhi. She was chairperson of the center during 2018 and 2020, and director, Indian Institute of Dalit Studies, New Delhi, during 2015-2018. She started a teaching career in 1990 when she joined the International Institute of Population Sciences, Mumbai, as assistant professor. She has been visiting fellow at Chinese Academy of Social Sciences, China, 2012, Ball State University, USA, 2008-2009, University of Philippines, Population Institute, Manila, the Philippines, 2005, East-West Center, Honolulu, Hawaii, 2003, and University of Botswana, 1995-96. She was awarded the Asian Scholarship Fellowship, Foundation Fellowship in 2005 to research on health and sexuality among the Filipino youth. She published a book and 2 papers comparing the young people in the Philippines and India based on this research. She has traveled widely to countries like Sri Lanka, Bangladesh, Germany, the Netherlands, the UK, the USA, Canada, and Finland in academic pursuits. She has chaired sessions, given keynote addresses, and attended national and international conferences. She has published extensively in peer-reviewed journals on the issues of health and social exclusion, with focus on youth and development, gender in urban spaces, and Northeast India. Her current research is on social discrimination and exclusion in access to resources among sanitation workers. This is a multi-city study conducted in Ahmedabad, Bhubaneswar, Delhi, Gangtok, Nagpur, and Surat. She has 3 books and about 30 articles to her credit. Her recent works include co-edited books titled Marginalization and Globalizing Delhi, Issues of Land, Labor, and Health, 2017, and Health, Safety, and Well-being of Workers in the Informal Sector Labor, Lessons for Emerging Economies, 2019, both published by Springer. She has also been invited for discussion on radio and television. Her recent publications in popular media on COVID-19 range from Hindustan Times, Outlook to Gender, Forum to Youth, Ki Awaaz, Counterview, and Countercurrents, where she has expressed her anguish on the issues of migrant workers, sanitation workers, women, students, elderly, and the other vulnerable populations. Her views have been quoted in India Today, Al Jazeera, Russian newspaper, Izvestia, and BBC Hindi. She teaches courses on research methodology, health services and the community, population issues and family planning program in India, social science issues and community health, and social sciences towards an integrated approach, urbanization and public health, and population health and development. Friends, today we have Dr. Sanghamitra Sheel Acharya talking on a very important topic called, this is combating COVID-19 and gender divide. So over to you, Dr. Sanghamitra Acharya. And friends, after that, we'll have question answers, and then we'll also have a word from Govind Kelkaji, who's also chairing the session. So over to you.
Thank you very much, Dr. Singh. First of all, I really want to thank IMPRI for giving me this opportunity to share some of my ideas with the community that IMPRI has really impressed, and I can see the participants who have been part of your earlier lecture series too. So thank you very much for that. Perhaps what I'm going to do is to bring on board some of the thoughts which have come to my mind as I have read about COVID-19, as I've worked on certain areas vis-a-vis gender and development, particularly from the lens of health, since that's my area of work. So I'm just trying to perhaps put some of these ideas together. I'm drawing largely from the international publications which are talking about or giving us information on COVID-19, what COVID-19 has done to men and women of different vulnerabilities, a couple of papers that I have managed to write on this issue, and of course, the data that the ministry has provided provided us with. So I'm just going to perhaps put all of these together and raise certain questions in how do we actually think about women, particularly in the in context of what we are trying to understand as gender divide. And given the fact that we are in a kind of social setup wherein this gender divide is not anything new, we perhaps have learned to live with it. Of course, there are struggles to minimize the divide, though. So that's perhaps what I'm going to do through the discussion, through some of the slides that I would want you to run through as we move ahead in what I share with you.
Sure.
So, okay, I think I have to move backwards to the
First slide, yeah.
Yeah. Okay, so I'm trying to move back.
Yeah, take your time, no issue. No?
Yeah.
Don't worry. Yes.
These things become quite intimidating, if I can use the word that way. As it is, like doing the class on speaking into the screen itself is
Yes.
very, very disturbing. So.
I know.
But ma'am, very beautiful slides. Yes, ma'am. Please.
Yeah. It's a good,
I hope
overview now,
they'll
It's a
make
good
as much
overview.
sense too, I hope. Okay, so here I am trying to perhaps point to us what have been the efforts to recognize what the pandemic has been. And in this recognition, where do we place the differentials that have come forward from the very social stratification, from the very gender stratification in which we are located as a society? So from that perspective, perhaps I would want to question the very idea of most often when it is said that disaster, disease, these are the elements which don't seem to be discriminating. But when we look at the outcomes, when we look at the consequences of these events, be it disease or disaster or anything of sudden calamity that happens, we see that those who are vulnerable, be it women, be it poor, be it those on the social ladder at the lowest rung of the social ladder, are the ones who are most badly affected. Now, so for that context, perhaps I'm sure I would want to therefore argue that in this process of how it translates itself, how a pandemic, for example, translates itself in affecting men and women differently, brings out those brings out that divide, places that divide, and therefore we need to respond to it separately also with different kinds of strategies that we need to put in. And therefore, to respond to a crisis such as this, it is important to have an approach which encompasses inputs from the society in a totality. You have to perhaps bring on board the very set of women who are vulnerable, and those perhaps who are the gradations of vulnerability across men and women for sure, but even among women, when we see the gradations of vulnerabilities differ given their propensities vis-a-vis economic propensities, given their propensities vis-a-vis their social status. So it is perhaps important to see how do we look at the social context, the political and economic context in which the response to COVID-19 has been encased, not only in the country, but also at the global levels. And that's where perhaps we draw, I wish to draw from the documents which have been internationally collated together based on the national data. And they tell us that the pandemic certainly has impacted women and girls in a far more vulnerable ways than perhaps men and the boys. And therefore, perhaps to combat the pandemic, we need to have different kinds of strategies. The first thing which comes to my mind in this context, therefore, is the very idea of the empirical information which has been generated for the pandemic per se. And when we look at our data set, which is what the ministry and the state bodies have been releasing, it's appalling to note that the gender disaggregated data is not yet available to us. If you look at the UN Women website, which is collating the data for pandemic in terms of gender, we as a country have not been able to provide gender disaggregated data. Therefore, we don't list there, we don't figure there. The gender disaggregated data that we have at our disposal largely comes from the crowdsourced agencies, crowdsourced data that has been collated. Therefore, much of the information that we have at the moment comes from UN Women and the WHO, who have been trying to collate data and empirical evidences from various countries to put together and have a perhaps consolidated concern that can be put forth in terms of the responses that the countries individually and global response to can be generated. So when we take cognizance of the fact that the very basis on which policies can be made itself is a bit of a, it's still not there in place, perhaps it becomes very, very important to consider what all has the pandemic done to the women. The first thing which comes to my mind is how women have become more vulnerable because of the pandemic, during the pandemic. Violence against women hasn't been anything new, it's always been there, but pandemic has further made them more vulnerable. And if I quote from the UN Women itself, about 250 million women have experienced some kind of violence against them before the pandemic. And since the pandemic has broken, there has been further increase, and much of the increase perhaps has been reported to have occurred because of the measures which were taken to take on board the ways through which the pandemic can be controlled. One being staying at home. Now, staying at home with somebody who has, who could be the perpetrator of the violence against women could have been one of the major reasons to have escalated the violence that was experienced during these pandemic times. So when it comes to women who could be, say, for example, who are at the front line of the pandemic as doctors, as subordinate level workers, right from, let's say, the nurses or to the cleaners in the hospices, or they could be in the much of the women are in the informal sector in the less developed and the middle income countries, we know that, unlike the developed countries where in informal sector there are more men, but in our case we have more women over there. So to bring those women on board in terms of what could have happened vis-a-vis the stop that occurred, everything that got stalled because of the pandemic induced lockdown, for example, a lot of women had to navigate through all those problems in terms of making sure that they will be able to overcome the problems which were induced because of the scenarios which the pandemic brought on, placed in front of them. So it's not only that women who are in these essential and essential services, even those, particularly more of them who are in the informal sector, their risk to violence, to be exposed to violence, got kind of exaggerated. And I'll come there in a short while as we go ahead with some of the data that we managed to put together. So it's important to take note of the fact that these vulnerabilities therefore have also impacted upon their economic propensities, and therefore also their exploitations which could have happened both in terms of physical as well as viabilities which could provide them some kind of economic remunerations. So moving ahead from there, something which therefore becomes very important to take cognizance of when we disaggregate the data on COVID-19. Very, very starkly, we note that when it comes to the world scenario, we have about 47% women versus 53% men. But when we look at our scenario, we have 35% women who have been exposed to the pandemic or have contracted the pandemic, as against 65% of men. So the pointer here could be, and we probably need to take note of, in the backdrop of the priority which is given to the health of women. Now, with that question in the back of the mind, we might want to again question the figures that are at us, or the difference that is visible in terms of men versus women, or the ratio that we see in terms of men versus women in India vis-a-vis the global scenario. So, and we know fairly well that the priority to women's health is fairly low, and therefore there is a likelihood that by the time you've responded to taking cognizance and the required health care has been received, there is a possibility of a lacunae over there, that the reporting could be of a miss. Contrasting that with what is the kind of healthcare support that we have perhaps put in place. Something which is very, very important. Sorry, excuse me for this. Sorry, that's the problem of working from home.
No issues. Yeah.
So the point I was making is when we started gearing ourselves up in terms of responding to the COVID scenario, as early as May, if you look at the information that we have vis-a-vis the kind of support in terms of the facilities, in terms of the personnel that were available to us, isn't very kind of assuring. We had just about 0.53 persons, if we can think in terms of the physicians per 1,000 population. We had 0.8 hospital beds per 1,000 population, and nurses and midwife, again, it's 0.31. So I should have probably contrasted with a couple of other countries. Even our neighboring countries seem to be faring a little better than us, for that matter. And perhaps this also reminds us of the fact that when we look at the public spending in health, we still are fairly low, 1.17% of the total GDP that we kind of put aside for health. So perhaps that gets reflected in the kind of support we have at the moment, or we had at the time of this pandemic approaching us. So in that backdrop, I think it also becomes very important to take note of the time that we took in putting in place the system that was required. So what do we see by the time we kind of move forward into April and May and June? We have 3-tiered first facilities which are put in place. There are dedicated COVID hospitals, dedicated COVID health centers, and dedicated COVID care centers which are put in place. As per the hospitals, they were to offer the comprehensive care primarily to those who could have kind of contracted, and therefore at the highest tier, they were the units to serve the infected people. And then you had the health centers wherein any symptoms of any clinical observations with moderate kind of reflections could be taken on board. And then you had COVID care centers, which were a little kind of milder nature. So there were efforts being made by the state in order to put certain kind of structures which would address COVID. Something which we probably need to take note of was that alongside COVID, other morbidities also existed, other mortalities also existed, and they were happening simultaneously. But what happened was that much of the support system was geared towards COVID for all practical reasons. And therefore, the information of what was happening to these other morbidities and other mortalities, we kind of have a very, very patchy kind of information on that. Nevertheless, by the time we get into, let's say, early May, we have more than 7,000 facilities spread across nearly 500 districts, which included from the range of isolation beds to beds for the confirmed cases, to suspected cases, and of course the oxygen supported beds, with also other facilities with oxygen manifolds, etc., etc. And in May, the rate of test was something to the tune of 300 to 350 tests per day. And today, in the morning news, what the news caption says, we have reached the number which is to the tune of about 15 lakhs per day. The tests are happening. Okay, so and of course the recovery rate. But recovery rate for us has always been better than most other countries right from the beginning. And today, in fact, we're close to more than 90% of the recovery. So something which perhaps becomes, or rather, I would want to raise that as a pointer for us to think, given the kind of, if I may say, poor healthcare system that we had, to my mind, it probably was more appropriate to concentrate on the illnesses which were critical, the cases which were critical, because much of that, which later on, subsequently, the guidelines seemingly have imbibed on, taken on, if we had concentrated on the critical cases, perhaps the required infrastructure, required support from the health system could have been concentrated to address that rather than spread it all across, even when the care could have been provided at subordinate levels by subordinate workers, even in terms of home isolation also. Nevertheless, this is how we perhaps moved ahead, and this is where we've reached in terms of the changes that we probably saw. Now, something which becomes more important to my mind is to see the difference between the private sector care provisioning and the public sector care provisioning vis-a-vis COVID-19. Now, the difference anyway exists when we come to public and private sector service provisioning. Most of the time, we believe that private sector is going to offer us better services, and public sector is crowded. It doesn't serve us, kind of give us the kind of services that we may require. That's the popular notion about public sector versus private sector healthcare provisioning. But if we look at a lot of literature suggests just the opposite. We still have access to care being provided by the public sector to a much larger chunk of our population as compared to the public sector. Nevertheless, despite the fact rather that we have almost double the number of facilities in private sector that are there in the public sector. So while private sector kind of geared itself up for addressing the requirements of the COVID-19, what is notable that the cost incurred to avail from the private sector was far more than that which could have been made available through the public sector. In fact, public sector was virtually free of cost. So what was needed, what was perhaps still not in place very strictly, was the regulation of these pricing mechanism for the services which were being put together in the private sector, right from the testing to offering the bed and the services related to bed in terms of oxygen cylinders, etc., or everything that was related to it. So that was something very, very important to take note of. And I really wish to put this very categorically, because while the number of private sectors are almost twice in the country as compared to the public sector, what's important to note is when it comes to the health insurance, it's very, very important to note that almost 80 to 85% population across rural and urban areas is not covered under any kind of insurance. So with that kind of backdrop, if we have options, very poor options to opt from the public sector services, it really becomes difficult to be sure of where I will be able to fend for in terms of my health. So this was something which really needed to be taken note of. In addition to that, there are also evidences, particularly in the public sector, if I may draw from the health statistics, the kind of positions, the number of positions which have been left without being fulfilled, the positions are still vacant. That also perhaps added to the burden which pandemic had caused on the health sector vis-a-vis the care that was needed to be taken. Now, in all of this backdrop, when private sector care is more expensive, perhaps more challenging also to most of the population in the country, and with the priority given to women's health care at a much lower rung, there is a likelihood that the care which could have been provided was not being able to be provided because of the constraints which were therefore generated vis-a-vis this kind of scenario. So when the pandemic started reflecting its, when we start looking at what happens vis-a-vis as a result of the pandemic, as a result of inaccessibility to certain kinds of resources which could have been useful for women, which could have made any indent in terms of their health and in terms of their identities, individual selves also. The worst thing perhaps that could have happened is the very logic of staying at home. And I am connecting it with the whole idea of the violence against women, because I said in the earlier also, if I had to stay with somebody who was the prospective proponent of the violence against me, perpetrator of the violence against me, staying home alone without any connect with the outside world which was available to me otherwise in case of any violence that could have been done to me, as an individual, as women who were exposed to such violence, it was very, very difficult to move ahead with. So that kind of risk, exposure to the risk of violence further got increased. And on the other side, it was also evident that perpetrators could also, and it's reflected through the studies which have come up, even the NCW's data suggests the same, that the very idea of restrictions due to COVID-19 were used as a control over women who were exposed to the kind of violence, as men who would be engaging in violence against women. The fact that they were the ones ensuring whether women can move out or not move out of the house, can seek help or not seek help. Moving out wasn't possible in any case with the kind of restrictions on movement. So these were the issues which have yielded the kind of or enhanced the vulnerability of women as against the otherwise such scenarios. And they have also led to the kind of anxiety and stress which has kind of been brought about. So while movements, restrictions on movements have impacted on any kind of redressal access to services which could have allowed redressal into the kind of violence which could have been otherwise avoided. It aggravated it. And therefore, sometimes on the pretext of this, even the essential items were denied to the women for that. In that sense, information wasn't also shared. So some of these become very, very kind of detrimental for women vis-a-vis the pandemic. Another aspect of violence against women, if we kind of zero in on domestic violence, by the global figures, we get a sense that during the pandemic, almost 25% surge was recorded across board. While before the pandemic, it was less than 40% of women who kind of experienced and reported violence. We see that post-pandemic, if we take on some of the countries, Singapore, for example, I mean, we perhaps imagine it to be a more civilized, quote unquote, and we see the level at which domestic violence has increased over there. So, and in our case, we see that it's almost like 100% increase in reporting of the domestic violence against women during the pandemic. So something which perhaps becomes very important to also note is that to perhaps when as a working woman, you're moving out, you are also escaping the chances, the probabilities of that violence being kind of lashed out against you. So the closure of non-essential businesses also kind of took away the respite that women could have received in case they were working in those businesses, right? It's only the essential services which were continuing to work, the banking and the cleaning, to my mind, the two, that, and of course the health sector. So this further aggravated the kind of insecurity which could have made women far more vulnerable than they could have been, than they were before the pandemic. And just to kind of 30% anyway translate, we know that 1 in 3 women globally have at any given time point face some kind of violence against him, and most of the time it has been by their people who are known to them. 92% in our case, in fact, the sexual violence occurs to them, to the girls and women, by people who are fairly well known to them. So pandemic seemingly has aggravated these chances. So when we take note of what was happening, or we zoom in into what was happening to women in India, 1/3, like I said, global scenario, and very much in our case also 31% of ever married women have kind of reported to have been subjected to any kind of violence by their intimate partner. Like I said, way back in April, May itself, the National Commission of Women, mid-April, came out with the information in terms of the calls that were registered vis-a-vis the complaints, almost increased by 100%. And what was interesting to note that because, of course, mobility was restricted, so most of the complaints, in fact, all the complaints were through electronic medium, email, and the WhatsApp number, which was kind of given. So something which kind of when the proposal to stay at home was used or suggested to address the pandemic, it was largely to ensure that there is the communication, the interaction between human individuals will minimize, which will therefore arrest the spread. But perhaps it did that also. But what was detrimental in that doing was leashed out more broadly and more necessarily on women and the girls, as evident as compared to perhaps men for that matter. So this was something which we perhaps need to note. Something which also becomes important to take note of is the fact that those women who could manage to kind of take up something in order to register the complaint, to go beyond the complaint that has been registered and see that something happens to that complaint that has been done. The result was that all the system, all the arms of the system were taking care of COVID, and therefore other alternatives which were required to take these cases further, take these complaints further, really were taking much longer time, or were perhaps put on the back burner when it came to the redressal. So some of these things became very, very important, become very, very important to take note of. Then if you look at women who engage as care providers, we note that globally and even within the country also, we see more women engage in healthcare provisioning. 70% of them of the care providers are women. But very dramatically, we see that when it comes to the bodies in decision making, they're just about 70% of women who participate in any kind of decision making. And the best of the countries where we see higher infections happening, Spain and Italy, for example, the scenarios aren't very different. Also, perhaps to take note of European countries whom we probably project as better than ours, still also have a similar kind of scenarios. So, but what is important to perhaps then question is, when women are contributing a lot in terms of their share as members of the health workforce, particularly as those who are at the front line, as nurses, as midwives, as workers as frontline workers, ranging from the cleaners, the launderers, etc. We do not take count of the kind of work and the kind of exposure, therefore, these women have got as care providers of the COVID. Now, if the proximity to the infected is something which is important in contracting the infection, in kind of taking care of the disease, it's also important to note, therefore, that those who are at the subordinate levels of care provisioning, and majority of them are women, are also therefore exposed to the infection far more than what the men could be. They are paid much less than their male counterparts, and like I said, they hold much fewer leadership positions, any positions in the decision-making bodies. Interestingly, when we've been talking about the personal protective equipments, etc., a lot has been said about it. Lot of additional PPEs have been brought in also. I think we started considering that way back in March itself, and the ministry, on the recommendation of Ministry of Health and Family Welfare, the mask, etc., were kind of requisited and put in place. What's important to note is, most of the time, the size of the masks and the protective gears are more attuned to the male bodies as compared to the women bodies. So even if the equipments are available, they're perhaps so ill-fitting that they don't really support work. They rather obstruct work than support work. So therefore, the first thing perhaps we need to take note of, therefore, is to ensure that that sensitivity towards the needs of the women, the gender sensitization among those who are requisiting equipment such as these, those who are sitting there to create policies such as these, have to be there. PPE is supposed to be very, very unfriendly, even otherwise. And with that, maintaining menstrual hygiene, for example, the sweat and using the lavatory, etc., had been reported as big problems while using the PP. So I think that becomes something very important to take note of, particularly in case of women providers, because another thing which becomes important is the flexibility in the time of their service hours, particularly because they are also responsible to their familial roles far more in a far broader way than the men. We all know very, very conventionally, when women come back from work, they are the ones who also will enter the kitchen to ensure dinner on the table, to ensure lunch on the table, whereas men need not necessarily be responsible for it. So those kind of flexibilities also need to be put in place vis-a-vis women workers. Now, if we look at the scenario vis-a-vis our situation, something which is very, very important gets reflected very, very similarly as it has been in the global scenarios. We have a larger share of women in the health workforce who are at the subordinate levels as compared to the higher levels. So if you look at the ratios that I'm sharing here with, when we look at the doctors ratio, it's 5.1 to 1 women, 5.1 male doctors to 1 female doctors. When we look at the subordinate level nurses and midwife, we see it much, much lesser. So the point again, therefore, is that the nature of work vis-a-vis that is attributed to women and their role in the decision-making bodies do not gel well enough, and therefore perhaps the gaps in the kind of requirements, the support that is needed in terms of elaborating on the working hours, in terms of elaborating on the kind of equipments they could be requiring, does not seem to be getting reflected in the outcomes. So so that perhaps becomes extremely important for us to take note of and consider that. If we look at some of these issues when we try to disaggregate what's happening to men versus women, we all would agree that when it comes to access to decent work, and the kind of benefits which can be accrued, such as health insurance or unemployment benefit or other social benefits, worldwide we see that out of 2 billion workers in informal employment, just about 740 million are women. And like I said, in developing countries, there are lesser women who are in the informal employment as compared to middle and less income countries. So if we contrast this with what is happening closer home, we see that the women in the informal sector are far more than men, if we can disaggregate that. Now, if we see among those workers, what's very important to note is like about 82 to 83% of them have no written contract. So in any case, you are in the informal format of work and there's no written job contract. You are not eligible to a quarter of them, about a quarter of them are not eligible for any kind of paid leave. There's no social security which can be availed by these men and women. And of course, if you look at the health insurance quoting the NFH's data, we see it's just as low as about 29%. And that's for the overall population. We can kind of make a rough estimate about what could be happening to the population in the informal sector. So in this backdrop, I think prioritizing women's health takes a very different kind of priority. Priority perhaps doesn't remain anymore as to be given to women's health. So why this also happens has something to do with something which is happening at the global level also. If we look at the most poor across the globe, half of them are women and girls, and they are the ones who are living on less than $2 a day. Now, with this kind of economic propensity and the kind of measures that have been taken to curtail or to combat the pandemic, there is a likelihood that the vulnerabilities are accentuated for these women and these girls, particularly when we see that women and girls anyway have had certain access to certain resources is already restricted for them in many scenarios. Say, for example, those who are uh, in the conditions of poverty will have restricted access to, let's say, clean water or perhaps toilet facilities. And much of the violence against women, let's take note of, is reported uh, while using a public toilet, particularly in developing countries, South Asian scenario, for example, if I may quote from there. So the propensities which uh, could could reduce vulnerabilities are just not there, and there are very bleak opportunities to improve upon uh, those conditions also. So in that backdrop, healthcare systems are already overburdened. Without any support for availability of clean water, the strictures of washing hands, strictures of maintaining distance, for example, in the crowded slums, for instance, it really doesn't fall viable when we need to ensure all of that. So it kind of doubly impacts upon women vis-a-vis their own personal hygiene, menstrual hygiene, for example. In crowded places, it becomes very difficult to be able, lack of water also for that matter. So something which could be very specific to the well-being of women, for example, pre and postnatal care for women, access to sexual and reproductive health, including adolescent reproductive and sexual health, life-saving support that some of these survivors of violence could be requiring. So this perhaps makes us think about where are therefore the gaps which need to be plugged when it comes to taking note of what the pandemic has done to the women. Now, if if we take note of scenarios such as this, particularly if half of the women, half of the poor are women and girls, and the access to resources is so dismal, abiding by the guidelines in order to ensure what has been said, hygiene, personal cleanliness and hygiene, perhaps remains a big question mark. And therefore, if we kind of relate it to what was happening closer home, we do take note of the fact, especially if I could draw from what was happening in the camps of the urban centers where the migrants who wanted to return to their native places after the lockdown was announced were put, and what was happening to the access to water, what was happening to the availability of the toilets, and even the food packets which were being distributed for them. We have in number of stories, not only from what was reported in the media, but one of the rapid studies which we've engaged in also throws up some very live examples which suggest that distribution of these resources which were for these people who were put in these camps to ensure that they remain safe before they can return to their respective places, perhaps the judgment of putting them in those camps was a bit of an array, because the close proximity with poor availability of water and toilet facilities did not allow the kind of hygiene and the disease distancing which was required in order to put on board the check which was needed. And therefore, a lot of suggestions come in from this very idea that these migrants, when they actually reached home, probably had already contracted the illness, and by the time when they reached home, the infection was full blown and was more evident in the form of infections that were seen in the places of where the migrant workers reached. So if we look at some of the figures which come up both from international agencies as well as national agencies, what was also happening in terms of, like I said, besides COVID, other morbidities and other events were happening. Something which was very appalling for me to note as I was doing the study, that the Maternal and Child Health Center of All India Institute of Medical Sciences was reopened only in the first week of June, after the first unlocking had set in. So the first question which perhaps comes to mind is, what was happening to those women who required ANC care, who were delivering babies during that period? And it's interesting to note also that the home deliveries during that period, particularly March, April, May, has kind of risen as compared to earlier months of the year, and even perhaps even the previous year for that matter. So something of this nature really becomes important for us to take note of. What will happen to these 20 million births which probably have occurred in these times, wherein whether the ANC was provided, if the ANC was not provided, what will happen to these children who will be born minus some of these requisite immunization that they're reading. The other important point which perhaps becomes also necessary to deal with is the kind of work these frontline healthcare workers engage with. Most of the time in rural areas, more than 3 million of them are the only kind of support which is available for all kinds of illnesses, all kinds of ailments over there. So what is important is to then consider certain kind of systems of infrastructure, systems wherein the support can be built in over there. These are the healthcare workers who have been actually moving around to identify cases, to track the contacts of these identified cases, and thereby exposing themselves to far more risks than perhaps in case if they did not have to move away from those kind of scenarios, from those places. Besides health, the other important aspect which pandemic seemingly has done, I am taking note of the time. I think I've already overshot my time. I'll just try to perhaps finish in another 10 minutes or so. So the other pointer is in terms of with the lockdown having descended, all economic activities having kind of closed, there are evidences that more of them perhaps would not be able to return to their work as perhaps they could have managed to do it. Something which is very important to take note of, which I said earlier also, the share of men and women in the informal sector employment. Globally, while there are lesser women in less developed and middle income countries, there are more women in the informal sector. Now, with that, perhaps what becomes very important is the vulnerability therefore increases far more. Now, as women who are earning and lesser than men, there are likelihoods of therefore saving less also. With that, the insecurity of employment perhaps also puts them into the kind of inaccessibility towards any kind of social protection. And I have already stated that in the scenarios vis-a-vis health insurance, for example. So with all this kind of propensities which are not non-existent for them, to be able to absorb the shock, suddenly you have no work and therefore no money to deal with, is much less than what it can be for women. And across the globe, the UN Women data, which has been collated across countries, suggests that women are losing their livelihood faster than men. And also they have they are the ones who have fewer alternatives to generate in any other form of work for themselves. And again, it's also because of the divides that we see in terms of the different kinds of propensities that are existing for them. And therefore, I think it becomes very important for us to take note of that. If this kind of scenario prolongs for a long period of time, the multiplicity of the vulnerabilities for women and girls will probably be such that they'll spread and be visible in other aspects also. For girls, education will be another important factor that will be impacted, and I'll come there in a short while. uh, in case of protection or extending some kind of protection to the workers in general, what was done by the Ministry of Labor was issuance of a government order which ensured that those who were engaging in small and medium enterprises, their wages will be protected. However, we really did not have any way to monitor how was this protection being actually executed, because on the one hand, while there was a need to ensure that the wages of the laborers particularly was put in place, there was no viable suggestion for those who were the employers, in the sense that if the machines, for example, if the factories were closed, how would they be able to generate the kind of income and be able to provide the wages? So that was a question which comes through even when we explored these questions on the field vis-a-vis our work. So this was something which becomes very important for us to take note of vis-a-vis what's happening in the international level. And in the same realm, therefore, I think it's also important to note that 22% women and 19% men, those who are employed as per the UN figures that we have, are earning whatever they are earning, they continue to remain below the international poverty line. And when we equate that with our scenario, we see that the proportions are much higher. 25 there are nearly 25% women who work for cash, and 23% who work of these women who work in urban and rural areas. 25% are in rural areas. So the vulnerabilities seemingly have a lot to do with what is happening in terms of not only how state stipulates a certain kind of protection, certain kind of scheme that could be put in place, but also the way that scheme could be translated. So that perhaps become very important, and we can actually contrast it with the international figures also, for that matter. quickly moving ahead to yet another scenario is when we talk in terms of uh, how women are rendering the kind of services without any payment and without any remuneration to them. And it's really notable that much of the work that women and girls engage in remains invisible and is unpaid, and that is actually the basis of how the world's economies are kind of maintaining the regular daily routines that they have. Before the crisis started, women were apparently doing 3 times more of the unpaid work as a vis-a-vis, particularly the domestic work, as compared to men. But what happened vis-a-vis the lockdown, vis-a-vis the social distancing, uh, the demand to have more out of what women could be doing otherwise, especially with the closure of the school, ensuring that the children who were in the family, particularly the school-going children, will have to be catered to in terms of ensuring that they sit through the classes. If there were elderly family members who needed some care, it was the women who were supposed to, that also gets extended to this women whose work is freely available. There is a possibility that prior to the pandemic, there was a paid nurse, for example, for an elderly member of the household, which was coming. So some of these things added to the burden of the women who were otherwise doing 1/3 of the job which they were doing now. Interestingly, it's also noted that almost 1.5 billion students have remained at home since March due to the pandemic. And this is something which also becomes very important in our context, particularly when we bring on board the context of online classes. In one of the ideas which is also put forth is that the schools and colleges have reached their student, and therefore education perhaps has become easier for them. But whatever we might want to do vis-a-vis our digital context of learning, uh, replacing a face-to-face classroom perhaps is really, really difficult. We cannot really get there in any kind of any that replacement perhaps is not possible. And therefore when we put women in context of all this additional work that she's now desired to kind of put across in terms of her regular regimes of work that she had, minus the for instance, minus the domestic help that could have been there prior to the pandemic. Now with the pandemic having arrived, the domestic help being gone, much of the work falls on her. And the continuance and acceptance of unpaid work as a norm is globally recognized to be a very, very strong driver of inequality, and therefore leads to other kind of inequalities which can be pertaining to wages, which could be pertaining to incomes, even physical and mental stresses that can be taken note of. And therefore I think what was put across as a family time, it was assumed that um, uh, lockdown is going to give us time to be with the family, and therefore a different kind of interaction will be generated between family members. Perhaps too much of proximity has also been reported to have generated different kinds of stresses, ranging from violence induced to just induced because of the proximity. Closure of schools, especially with school level children, is not only induced the kind of stress that, because mother, to my mind, is the one who is largely associated with the responsibility to ensure that the child is sitting in front of the screen doing the classes. Now, till about yesterday, as mothers, we were all telling the children to stipulate the time in front of the screen, to ration the time in front of the screen. And today, as mothers, we're all making them sit in front of the screen. And I'm sure the next pandemic is going to be related to the eyes, the amount of screen time that we are all engaging in vis-a-vis all kinds of work that we are doing. So proximity, on one hand, which was perhaps seen in a different context to bring people together in the familial setup, probably has also become a cause for stress. It has also led to the kind of already the gender divide that we already have in the kind of household course. We may have men actually being able to enjoy the indoor activities much more than perhaps women and girls, who will be largely, who have reported also to be engaging largely in terms of doing their kitchen jobs and other household chores. So this perhaps is a kind of a stimulant to raise conflicts. Similarly, if we take note of women who have been who've been working essential services, like I said, when women continue to work as part of that services which are essential, uh, timings, particularly in case of healthcare workers, but even other workers. For example, if I take note of women who were working in the units which were selling essential items in the malls. Now, if the corridors are blank and the shops which are selling non-essential items are closed, the proximity to these blank stretches or not being being alone, for that matter, while walking through these empty passages, could be also increasing that kind of vulnerability for women. And therefore, even as working individuals, one might be stacked vis-a-vis the kind of problem that could arise as worker because of the pandemic. Uh, if you look at the situation of young people, something which is very important to perhaps take note of is uh, a lot of schools have kind of schools and colleges and universities have remained closed, and therefore students have remained out of schools also. Um, Something to the tune of almost 90%. Now, while students have been away, what is also important to take note of is some of the scenarios which have got evolved. Now, online learning could be feasible and possible for some kind of students, some kind of socioeconomic strata from which the students could be coming, some kind of places which are fairly tech savvy, connectivities are strong, etc. But it may not be the same when it comes to some other vulnerable places and vulnerable uh, situations. So it becomes very difficult to ensure that kind of parity when a learning process can happen that ways. So a lot of possibility is that when it comes to girl students, uh, there is a possibility that those who are already in, let's say, poverty in rural areas with other kind of disabilities, the likelihood of their discontinuing, not being able to reconnect with their learning processes is the possibility that we are seeing at the moment. And this is also evident from the earlier pandemics that a good number of, a large share of adolescent girls were not able to return to their education. One of the references that I would probably want to share here is while speaking to the students and other members of this this university college in one of the eastern parts of Uttar Pradesh. The first thing I was told that uh, the online teaching has been very detrimental for girls because girls do not have access to phones, because parents believe that this is detrimental for them. It's not good, quote unquote, for girls to use phone, and therefore they do not have phones. And laptops, of course, are yet another thing to think about. So in the absence of access to phones, online teaching for these girls has become a huge peril, and they're actually not able to take on anything in the name of classes. It's only therefore a lot of them are remaining without being able to catch on what is kind of happening vis-a-vis the classes. The other the other aspect is which we perhaps might want to think about is since a lot of youth comprise the workforce, and the way work scenario has been vis-a-vis the closure of employing units, unemployment is kind of one very important aspect which has hit the young people, and we can take note of uh, the levels at which the unemployment has hit the young people. Very quickly, something which perhaps is important to take note of also is the kind of uh, reflections that we get across globe in terms of places which have already been hit by the conflict scenarios, or in an ordinary kind of scenarios, in an ordinary kind of situation, we see that the maternal deaths in any case are fairly alarming. Even we, without any conflict, at least at national level, have not a very good scenario when it comes to maternal mortality. What has happened vis-a-vis the pandemic is that because the support systems have stretched themselves towards the pandemic, what was existing in the name of care has kind of shrunken, and therefore the burden on giving care, and also therefore vulnerabilities towards maternal mortality has increased in the regions which are conflict prone. Now, if we relate that with the camps in which people were kept before they returned to their native places, um, cramped conditions were affecting physical distancing in all possible ways. Violence, like I said, while accessing services to toilet facilities, which were largely public toilets, was another reflection, and was cited also as we spoke to some of them in terms of experience of harassment that they had, that especially young women and girls had experienced. So this is something which needs to be taken note of while strategizing how women can actually be taken on board when it comes to dealing with the COVID scenario in conditions which are conflict ridden. Uh, just to take note of the fact that while when we look at their participation in any kind of decision making, just about a little over a quarter of women who seemingly have been part of any decision making globally. So so this is something which if I just kind of extend it in terms of what was happening in our scenario, one of the cases which is reflected in terms of a daughter who was trying to escape the spousal violence and had come to her mother's house. That's when the pandemic occurred and the lockdown was announced, and she couldn't return. She didn't want to perhaps return to the marital family, but in the lockdown, in the lockdown, what also happened is that the brother, who was the breadwinner of the family, he lost a job, and therefore the crisis, the economic crisis of an additional mouth to feed, uh, kind of created situations such as that she reported to have got beaten up even by the brother. So these were the kind of scenarios, these are the kind of situations which have been reported in terms of what was happening to women. And like I said, diversions were causing a lot of gaps, particularly in the services which were needed, very essentially the health services and the police force that was engaging with it. Uh, some of these states, like Karnataka, for example, set up some centers labeled as Santwana centers to address the issues of domestic violence, for example. Delhi also had kind of certain functional helplines which were put in place. Uh, it was also noted in Delhi, particularly Delhi and another city, Chennai and Mumbai also, that the police force was specifically, as part of their regular regime, were collecting data on students, particularly women students who were residing in private hostels and children who were staying in care centers, to ensure that they were given the kind of support that they were required. But something which comes out very clearly in terms of new entrants to these houses, particularly the shelter rooms, that there are instances which were reported even when we were doing the field work, that the new entrant was kind of not taken in because of the fear of COVID, being COVID positive. So, and at least two instances that kind of were reported for us become very important to think about. Migrants, I'm sure we've heard a lot and we've read a lot about them. But in terms of women migrants, two things perhaps are important for us to take note of. One, as a worker herself, wherein having largely being in the informal sector, the experience of poorer propensities to be able to take an alternative job puts her in a vulnerable position. Second, as a dependent on a migrant worker, further kind of aggravates her condition vis-a-vis the vulnerabilities. Especially when you are at the lower paid, low economic ladder, your payments are much lower. That becomes something which really needs to be taken note of. Now, because it's in most of them being in the informal sector, low paid jobs, a lot of them as domestic kind of support workers, cleaners, laundry workers, etc. And all of good share of them is also in the hospital scenarios, remaining excluded from any kind of social protection. So much of this again exaggerates their vulnerability in terms of being able to take on an alternative. So this also further aggravates their economic conditions, since the work is lost, savings are low, they're in case of whatever remittances they could have been sending home, they also get kind of stalled, which also then affects people who could have been surviving on those in their places of origin. So as migrant workers, and let's also remember that as migrant workers, we might want to also take note of the larger frame of who migrants are. Most of the time we restrict ourselves in terms of thinking of the migrants in the informal sector work. In fact, you and I also will be migrants in some stretch of explanation for that matter. So this was actually, I found this very interesting because based on this question which was asked in Lok Sabha on 14th of September, this actually shows us the migrants who could manage to reach their respective places. So it's very interesting to note the dark shades of the states are the ones wherein who are who are the ones wherein the migrants return. So we can see these are the states which are less developed, the more developed states wherein the migrants have returned from. So something which perhaps becomes also important for us to note is uh, how the larger context in which we pose our migrant workers vis-a-vis the support of personal protective equipments, vis-a-vis the kind of food subsidy or the healthcare that could have been provided. One illustration that I would probably want to take on board is from the tea garden workers, particularly in Assam, wherein even after the lockdown was announced, it took a while before the tea leaf plucking could be put on hold, because that was the time when the first flush of tea leaves were to be plucked. So it took a couple of perhaps weeks more than otherwise. So the exposure to the probable infection continued for them as they worked without any PPE gears. And in any case, and a lot of women, I'm bringing this also because most of the tea leaf plucking is done by women, and their vulnerabilities continued to be there without any PPE gears, without any system in which they could locate themselves for doing the job which they were doing. So I think we've by and large spoken about these, but just to reiterate, perhaps what's important is to get the get the data which we need to uh, disaggregate in terms of gender, so that a viable policy can be actually put in place. Women who have been in shelter homes need to be provided the kind of hygienic systems, be it water supply, be it substance of menstrual hygiene, masks, disinfectants, etc., needs to be made available vis-a-vis their use. Uh, Second thing, which is, like I said, and I perhaps have reiterated earlier also, stay at home has really not been very viable for women for the simple reason that the perpetrators could be using the very idea of staying at home to their benefit, which is further detrimental for women. Particularly when movements are restricted and you really cannot move out of the house to save yourself in conditions of such exposure. So alternative systems beyond some kind of counseling or legal aid or telephone services, they perhaps need to be scaled up further in order to ensure that accessibility, wherein women can actually be able to access the kind of support systems. We have more of negative stories when it comes to ensuring reporting of these cases by the police. So something of the kind wherein women will feel comfortable enough to be able to go and register whichever way possible, with particularly now, perhaps when the unlocking perhaps has come to its fairly a long way. So therefore, some of these instances probably become very important for us to take note of vis-a-vis how do we ensure women who may have lost their work and would want to get on board vis-a-vis their work. So one of the aspects could be, when food, any kind of subsidy, for example, or food is being given, for example, perhaps has to be more in terms of the individuals within the household rather than on the basis of the household. That will at least reflect on or minimize the kind of dependence women could be having on men. That's one important thing which perhaps becomes very important. Some of the states have put in place some kind of monetary support also. Food Corporation of India has also kind of pledged the kind of something to the tune of helping 81 crore people to get the food. But the translation of these schemes perhaps needs to be monitored and also seen how it gets through, because we still have evidences of people who have collected spilled milk and kind of almost begged food on the highways to be able to feed themselves. So that's something which is needed to kind of strategically address how this aspect of pandemic will be taken care of. Media has its own ways in which it has taken on board the questions of COVID-19 and perhaps mitigating it also. One of the most perhaps that I have noticed, I may have missed others also, is the campaigns which the NDTV has joined hands with Dettol to launch. So with all this, another 2 minutes, Arjun, I'm really sorry for taking this long, but I just thought—
No, please go on. Yes.
When we come close to the time point wherein we've kind of unlocked as of now, right? I mean, I recall the 31st October when the announcement that the unlocking has kind of, we have to take care of ourselves. Now, if we today, when we take note of what was the scenario in April, just about a month or a few weeks rather, 19th of April would be just about few weeks. That was the time then when we were still just about half of the districts were reporting to have had confirmed cases. We were still very comfortable. But as we moved ahead gradually, and if I can recall the data that I have used, sometime in mid-May is that we see a sudden spurt happening in the kind of way infections increase in the country. So much so that when we see the data today, we kind of get the impression that while we have reached a figure something to the tune of 8 million plus, right? As compared to what we started with, 30th of January, we had just about one case and a spread of about 8-9 months. We are here. Now, when we compare the world figures with vis-a-vis India, right from the beginning, be it the infectivity, be it case fatality, be it recovery, and be it simple, numerical values of deaths that have been caused by the pandemic, we have fared much better than most other countries. We know this fairly well. I mean, the only problem to my mind has been that the kind of fear which has been created for this number, for this infectivity, has been something which we haven't managed to deal with very well. And I say this because, even now, when we disaggregate the figures across the states, Maharashtra is seemingly, the worst of state when it comes to the number of cases. But what is happening to Kerala? Kerala is the one which is adding most number last 24 hours. This is the data that I have for yesterday. The last 24 hours, Kerala seems to have added 7,000 more cases. Similarly, if we look at the active cases, Karnataka seems to be having most number of active cases, and again has added more number of active cases also. So the point I'm making here is when we look at these are the first 7 or 8 states which seemingly have had worst of the conditions. The point I'm making is, despite the numbers being large, if we see it proportionate to what was happening in what has happened in other countries and across the world, we seemingly have been fairly all right. I mean, the panic that has got created was not what was needed to have gotten there. What was needed to have gotten there was, how do we address this? And like I said, given the problems that we have in terms of our health system per se, the quantum share of the GDP that we have at the health center, what was perhaps more needed, that the critical care was addressed far more, with more vigorous responses as compared to the non-critical care, especially the ones which were milder and so on. And not that they did not need care, but the point is that they could have been handled even otherwise. So that's something which I would probably had wanted to say. And therefore, what was also, and I repeat again, that the empirical information which needs to be disaggregated by gender in order to be able to say what is it that is required for women becomes very, very important. This is something which I am drawing from a source which is not, this is a paper which has been published based on the empirical data which has been collected by by the researcher in IEG. So this is the information which we get in terms of how men and women are when it comes to both the confirmed cases vis-a-vis the deaths that have occurred to men and women in the country. Now, in terms of when we look at these figures, like I said, we need to take note of what is happening in terms of prioritizing women's health at one level. And also, if we look at the vulnerabilities of mortality, even among women vis-a-vis their own conditions of nutritional status, etc., etc. So when we look at women in our scenarios, we see that more than 50% of them in the reproductive ages are anemic, as compared to men. The 1/5, less, little more than 1/5 of them are anemic. So, anemic conditions are very, very strongly related to the immunities which are important for addressing or combating or being able to take care of oneself vis-a-vis COVID-19. So I think this therefore becomes very important to go beyond the stark numerical values. We also would want to see that despite this difference, this study also points out the fact that while, because of these problems with the reflections of the nutritional levels and the anemic conditions, there is, while Indian women, when they contract COVID-19, they are at a higher risk of dying as compared to men. This, of course, is the data which is restricting itself to just about mid-May. So the point, therefore, is that going beyond stark numbers in terms of what is behind those stark numbers also becomes very important. Who are these women who are dying? Are these women who are from what social strata? Which kind of hair care provisioning are they doing? Are they at the subordinate levels, or are they at the higher realms of the care provisioning? Because like I said, when it comes to women health workers, those who are at the subordinate levels are far more in number. They are the ones who are going to trace the contacts of COVID-19. They are the ones who are exposing themselves into the community, and therefore it's very important to disaggregate further, not only by gender, but also by who are these women who are getting affected in which way. And a lot of them, one of the reflections is that, and when I'm sure those, when we were reading and hearing about Dharavi and how Dharavi took care of its people who were affected by COVID, a good number of healthcare providers were the ones who were living among them. So, and again, by way of their economic propensities, a lot of them have to kind of choose to live in those conditions. And we know what are the propensities of living in the slums vis-a-vis housing, vis-a-vis water availability, vis-a-vis other requirements which perhaps are essential vis-a-vis the guideline when it comes to addressing COVID-19. So I think over and above these stark numerical figures, the characteristics of the people who are engaging in providing care, who are engaging in, who are getting affected, also becomes very important for us to be able to provide the kind of policies, to provide the kind of to be able to address what COVID-19 has done to women will be very, very important. I think I'm going to stop here. The rest of it is the references that I think I've taken, some of the references, largely from some of my work and some of my other work. So I'm going to stop here with apologies of taking almost double the time I thought I will take. Thank you so much.
No, in fact, thanks a lot, Professor Sanghamitra, Acharya ji. In fact, I have to say that maybe there's not any area that you have left in your presentation. You have covered the entire range, the entire gamut of issues that impact women. And I think you have done it so beautifully. In fact, and that's the reason why, I never felt like also telling you the time is up or whatever, because we wanted you to continue. And thankfully you continued, despite your cough and all, despite the disturbances and all. I think the important aspect which you bring out, I think I'm not going to summarize the entire thing because it'll be another talk. So I think what you brought out very clearly was that it's the most vulnerable who are differentially impacted compared to other people, and in that will be women, and the women will be Dalits and be further homeless, disabled. I think you keep on adding to it and the vulnerabilities keep multiplying, in that proportion. So that was, I think, very important thing. And then you mentioned about the whole society approach, that we have to address it holistically, not, in silos. I think that's where the problem has been, that the government is addressing in silos, Then I think at this point which you brought out was very, very important, which you also noticed, and maybe I'll share 1 or 2 points here, is that, staying at home, you are staying with the devil. You are staying with the perpetrator. And I must share here, Prof Sanghamitra, that, in fact, since we were part of the Delhi government's advisory panel for COVID relief, so we were into rationing, distributions and shelters and food and everything. And all of a sudden, midway, I started getting calls from young girls from Kanpur and all, saying that their father is bashing them up. Wow. And then there was a series of things. And then for that reason, I started a WhatsApp group called No Violence Against Women. And then I got calls from my own friends who were teaching the university and other places that there's spousal violence. And saying that, sir, how can I tell you, sir, even I'm facing it. So this was something which actually was totally hidden, and government kept quiet about it. NCW first said, oh, it's 100% rise. Then they started to say, no, actually we meant something else. Remember, they were checking it out, because I think this government didn't want to address it. The problem was that because, and somewhere I think in a presentation, I personally feel, and which I have also been saying it upfrontly, that, for many of us, I think the union government has failed miserably handling this issue. And when you say that disaster and, this pandemic and all actually increases the gap in society between people, it showed the worst face of India. Yes. That how things actually are problematical at the bottommost level as such, where the Dalit and the women and the children and girls and everybody were badly about the beds. And I think you came out with figures and all, which I think, I'm not going to dispute that at all. I think it's fantastic and nobody's going to dispute that at all. And I think, yes. And I think the point that brought out, I think, which I think many would have not noticed it, that even the provisioning of gloves and PPEs and all were actually universal sizes, which was universal means man, which is what a patriarchal set of culture is all about, in the country and the world also. and it obviously would not fit the women, and it makes it further encumbers them, So I think these are small nuances which provide, like how 70% care providers are women, but leaders among them are 30%. So this discrimination that happens in society, I think, is shown at all levels. And then also you spoke about prioritizing women's healthcare, and then violence, I think, using public toilets, and I think all that is very important. And somewhere I personally also feel, that some of the strong arms of the state, the police and all, they actually complicate the problems, They made things worse for women and for migrants and for the people who really they should cater to, by showing them away, by pushing them away. So many people couldn't get food because they were, they were moved away from the places. They were told to go inside the homes, and they had no homes. So where do they go? They go on the streets. Because we were working with the homeless people, we realized the problems that they were facing as such, So then, of course, I think, you bring up this issue of informal sector workers and all, which is very important. I think I don't want to get into that. Yes, I think you spoke about the family time, and the issue really is when the family is missing, and when the family means further oppression and discrimination and, a lot of work for women, what family are talking about? So even in the well-off family and all, even the middle-class family, I think the workload really increased 3x, 4x kind of thing, 4 times, 5 times kind of a thing. Yeah, 1 second, yeah. And I think this thing I want to, talk about because, my wife works with this school in Anupshire, which is Padara Asian Society. And they were the ones who, through their funds, because they realized that they couldn't open the school, they provided tabs to the girls. So first tabs to 12th class students, then tabs to 11th class students, then tabs to 10th class students, because they had gone to board. Wonderful. What they realized was till 12th and all the girls were bold enough, they could handle it. The moment the tab reached to 10th class students, the brothers and all started fighting with them. And they took the tabs from them, and then they had to actually do a lot of work in terms of handling the domination of the father and the male child, So I think this is some aspect, which I think we need to keep in mind also, like online education compared to men and boys and girls, I think girls fare the worst, and they have to deal with a lot of issues, which many of the people don't even realize as such, Well, I would just say that, it was fantastic listening to you. And since Govindji is there, and, I think you've added so many perspectives into where you brought in, I think you've not left one aspect, you have spoken about how in Dharavi, since the, healthcare workers were there, so they were able to handle this problem much better than in many other areas. So I think you have addressed a lot of issues. And, I would now hand it over to Govindji for our comments, and then, of course, to other friends from the, who are listening to us. And there are some question and answers also. Sure. In the section. I think we'll also repeat the questions,
Yes, ma'am.
Yeah,
yes. Sanghamitra, ma'am, if you can stop the share, then.
Okay, I will do that. Yeah.
Ma'am, if you can share the PPT, we will upload it on the website.
Sure, I will do
because
that.
It has so many very comprehensive, many information there. Yes.
Yeah.
Govind.
Yeah.
So our request to upload the PPT speaks for the lecture. It was really splendid. It was very comprehensive with the data. However, there are few questions that are coming to my mind. I mean, it's not necessary. One question is the nature of patriarchy in India and globally. And I think Dr. Singh also has spoken about that. That why in the home, which is considered a nurturing home, why there is more violence? We say if the man is there, the woman is protected. Singleness, single woman is vulnerable. But when the man is there, the woman becomes so vulnerable within home, outside vulnerable. I mean, this really raises the dichotomy. What is this nurturing? What is the nature of the family? And not only that, I kept me thinking that this brother who started beating her because there was an additional kind of thing. Yes. And we talk of law. Law provides the equal share in property and equal share in residence, and women's right to live in the house if there is a violence against women, irrespective of whether the husband owns or not, even if the in-laws own. This is the law in not very old. It's in 2005. After a great deal of a struggle, it was amended. So the law has become so ineffective. or we don't care for the kind of state doesn't care to implement it. So additional law, I think, I'm not saying that there should be no law. There should be no law, but I don't have any hope, Sanghamitra ji. If the laws are passed, then something would be done, kind of thing. And not only this government, I'm talking of the nature of the state as such, and nature of the family. That violence has existed there earlier, but now when the proximity increased, when the so-called head of the household came, he had the crown on him, and he began to rule with danda to everyone and the left and right, kind of thing. So this is the most kind of brutal, or we call it toxic masculinity, that we see in this kind of situation. So that was one thing. Policy implementation, I've said that policy is not being implemented outright, kind of thing. So even kind of this demand on the state for the policy implementation would be very good. Where does woman go? The resourceless condition. I mean, little bit of cash transfer, police attendance, all these kind of incremental changes. I mean, they need. I am not saying that they don't need, but the fundamental thing is, if the house and land or the any kind of property, what is there, is in the woman's name, even half of it, but half partitionable right, those women will not be beaten up. I did a case study of a Meghalaya, which is the matrilineal state, and you see the violence is really kind of at least less than 10% in there, and that also increased as an influence from the all around the patriarchal system. So question land, other property, the share of the woman, so she's not economically and otherwise dependent on men. We raise our children that brother would take, so why ipad, they would take everything whatever is kind of useful to them. And we laugh at children, but there is also this kind of right that they learn to assert that this is the boy's right, this is the men's right, and we should have it. How come you will have it?
Yes.
First is my right and I should have it. So this is the resourceless condition has to improve. And this is the time when the government is really asking this kind of high kind of 100% increase of violence. And of course, the European countries also 30% increase in France. And China, which is a socialist country, I am a great admirer of China. And what has happened in China, one of my former students, and then she's working where I'm a board member. Only today I learned that she has asked the organization that she would live separate because there is so much violence of her mother that she cannot tolerate. And mother says that, where do I go? This is the kind of thing. This is happening in the context of COVID. So it is not China or India. It is the question of resourceless condition of women. I mean, resources in the hands of women will make them stronger to fight for their rights, and that is the real cure that is needed. They will not be anemic then, they will be eating better, they will not be the last to eat.
Yes.
That the girl child would be allowed to live, they will not really get rid of the children, kind of, that is the this thing. And my last point is really about we should also do some kind of a study. Maybe you are well placed in JNU, that we can think of really Meghalaya, something state which is matrilineal, and which is that whether where the even not everybody, but the youngest daughter has the responsibility to support the family, and she inherits land, and their lineage is by the kind of thing. What happened in Meghalaya during COVID time, and compare it with any other state which is patriarchal? And I'm sure that there would be a lot of difference between the thing, simply why? Because the nature of the kind of system is so different. So systemic aspect we have to really unravel. It is not the kind of that data only, but why it is happening, why question is needed. But I thoroughly enjoyed your presentation. You were so comprehensive, and I must congratulate you. Thank you so much.
Thank you so much, ma'am. Arjun, do you want me to say something?
No, yeah, well, I think Professor Sanghamitra, like what I want to do is, like, there have been some questions also over this question answers. I'll read out these two questions, in fact, by a friend. And then maybe you can answer both Govindji and this friend, She says, just some reflections hearing you of the relationship of care to health, women's health, as presenter mentioned too, markers like violence affect health too. Domestic or close partner, intimate partner violence at workplace, wondering also the impetus to have women to be part of workforce in the ways it is being imagined today is also a patriarchal imagination. So it appears that, again, whether a woman is being productive or contributing to the workforce or is not, also determined by patriarchal markers, constructs. Honoring women's ways isn't prioritized, but women are asked to stand next to men and take on certain roles as imagined by men. When I see a huge problem today, which I see as a huge problem today, because how do women break free from the structure when even the freedom or what it means to be free is defined largely by men, with power in patriarchal setups, or by women that men choose to share the power with, who in turn violate other women on behalf of the patriarchal setup. The added on further is, I would add a basic universal income is something to be worked towards in terms of public policy, and further add some more factors to increase this basic universal income based on specific markers, vulnerabilities, such as single women, widowed women, senior citizens, women with disability, pregnant women, single pregnant women, or other markers, women without housing security, homeless women, etc. These indicators can further be looked as to determine if the basic universal income is to be increased or by what amount. And this can be perhaps an impetus for women to also imagine different ways of engaging or creating their own norms of what it means to be employed, stay employed, or be part of a workforce, etc., or find freedom or to continue to be engaged in society in ways women choose, or may make more room for other indicators that women may like, or to look at the well-being, mental health, creative productivity, relationship with ecology and nature, etc., that may also be equally important to a woman working woman's thoughts. Well, this has been put by Lynn Henry. I think so. These are questions which I think you can also take up, in the response. Until Arjun wants to ask something, or maybe Simon wants to ask something. Yeah.
Okay.
No, ma'am, can you go
ahead?
ahead?
You can go ahead.
Okay. I must say that these are some very pertinent points which we need to take note of the moment we start deliberating on the question of women and gender. As Prof Kelkar has very rightly said, I think it's the issue of resourcelessness which puts women in a vulnerable position, and that perhaps links also to the idea which this friend of yours has put across in terms of the question.
Yeah.
Looking at what is viable for women from the lens of men.
Yes.
Whether women is equal to or not equal to, etc., etc. That perhaps is the question which will be answered the moment we allow or ensure the kind of parity which is required in access to resources. If I can be having similar kind of access to the laptop or the iPad that you mentioned, I'm sure I will not have to fight with the brother or the male member in the family along the same lines. And therefore, despite the fact that I have equal access to the property of my parental home as compared to my marital home, still there are the social impediments which make me kind of do away or give my share to my brother, for example. So when I get together with Professor Kelkar in kind of arguing for overcoming resourcelessness, the point therefore I will think is important to take note of is how do the socio-cultural nuances impede overcoming resourcelessness. And that's where perhaps it's important to, I want to get back to the whole question of how do we in the society rear up boys versus girls. When we tell our daughters to dress up properly, come back home before it is sunset, etc., etc., we are already inculcating into the boys that, well, I can come back late at night. I need not be, doesn't matter if I'm bare bodied or anything of that sort. So, instead of telling the girls, I think it's more important to inculcate the respect which is needed for the girls and the women in the young minds of the boys.
Absolutely.
And those are the boys which will probably take note of this equality which is required to be able to ensure parity in access to resources, be it education, be it care, be it nutrition. And like ma'am, you said very rightly, if I have access to money, for example, I'm sure I will know, I will also be able to decide for myself where do I spend that money for that matter. NFH's data, if I can go back and relate from, while access to money in itself is something to the tune of less than 40%, making a decision to be able to use it on my own health care is as poor as 30 to 40% still. So despite the fact that even if we say 40% of women have access to money of certain kinds, to be able to prioritize my health still remains a big question, because before me as a woman or a young girl, there are others in the family who would have that kind of priority. So I am completely on board when it comes to enhancing how the access to resources of various kinds can be ensured for women in general. And again, we might want to disaggregate women on different axes of vulnerability further to get it to take it to the second level of. So I think I'll stop there for.
Okay, Professor Sanghamitra, I just have I think 2 points which I wanted to also raise was, I think you brought in this dimension very well about the private sector vis-a-vis the public sector. And I must tell you that I was one who kept advising my friends not to go to private sector, because last year I lost my sister-in-law to Fortis Vasant Kunj. It was a clear case of murder that they did, So I have been, even my friends were, with COVID positive, and I said, please go to LNJP, don't go to Max or don't go to Fortis, whatever. And I guess I was getting called from the family members, sir, please take them to private. I said, no private hospital, please. Public hospital is better in Delhi. So, this psyche in the, minds of people, that private is better, I think is also been created by the government itself. So government is the biggest culprit in this, By 1% of GDP, what rubbish is this they're doing? 2 is this government, which created so many data earlier, so much of data earlier, all fake, today tells you got no data?
Yes.
There were no data in terms of how many people migrated, how many deaths took place, when we all knew that over 300, 400 people died, migrating, moving to places, how many people were left without food and all. The country knew, and this government just washed the hands of saying they had no data. So the problem is, I think this entire COVID could have been handled much better if a union government had stopped playing politics. If it only governed properly, I think we would solve the problem. But the problem is that this union government was playing politics, like in Delhi, when Delhi wanted to go for the homestay that they could recover in the home. The LG was opposing. No, they have to be in the hospitals. And then what rubbish? When people can take care of the home, why do you want to further, in fact, burden the government institutions, And then the plasma therapy which came in. So much of this care was taken plasma therapy. So it's like, you are making things worse for the states which are not under your power. So I think it's like, much of the health could have been taken care of if a government had only governed, had listened to people, had listened to the voices of migrants. I think, so I would say, if there's any problem, if the vulnerabilities increase in the country, it's increased because of what the omission and the commission of the union government, That's my take.
Okay. In fact, you brought it very well, Dr. Singh. In fact, Meghalaya for a very long time, if I recall correctly, still has not reported a case as of now. So to just put it across, like Professor Kelkar says, that may be really a wonderful thing to explore this, comparative analysis across another state and Meghalaya, for the way they have taken care of their populations, and what is it that we can learn from. Private sector hospital, Dr. Singh, if I may just share part of
Yes.
the study which we've been doing, we
Right.
kind of use the audit method to check on how these private hospitals are admitting people. So two of the hospitals in Delhi, Fortis being one of them, we checked the website and the availability of the hospital. And then we made the phone call for the hospital. So when you're, first of all, it took us at least 3 to 4 kind of calls before we could actually connect with them. And then they say that the beds are not available. So we said, this is what your website is saying. So the contention was, by the time you've seen the website and you've made the call, beds have gotten over, which was, I mean, not a span of 4, 5, 6 days. We were doing it almost every day. The calls were being made. So, but the person who was at the reception says, not to be quoted kind of in that mode, that see, we write that because the government wants us to give some figures vis-a-vis availability of the thing, but we do not want to get into doing that, because with all the due share of the 10% of the bed count have to go for the poor people and so on. We do not want that to happen. I mean, that's the explanation given, meaning to say that even if the beds are available, we are not opening the beds for the COVID patients. So while the resources, like you said, are all going to the private sector, if we look at the Niti Aayog's chapter on health, it very categorically says that the resources from the public sector hospitals can be used by the private sector units, but the returns need not necessarily be shared. So what does that mean? I mean, I still would want to make a kind of, but it says very explicitly that while the resource sharing can happen, but there's no clarity on how the returns will be shared vis-a-vis the public sector. So if this is the mindset with which we are moving ahead, I'm sure the problems will continue until and unless we take note of some of these aspects and work through.
Yeah. Thanks a lot. Yeah, it reminds me of this point.
Yes.
Yeah, Arjun.
Yes, ma'am. Thank you so much for giving such a very nice lecture and covering so many points. I've written many things, but ma'am has really highlighted the various diverse needs of diverse women, be it rural women, be it a young woman. There is global, various sort of cohorts of women, and the needs really is very diverse, as Indu sir is also mentioning. So we have the largest UBI program through the Jan Dhan account to women, but 500 rupees. And we have been arguing that half a liter milk comes for 20 rupees. By even that standard, the 500 rupees is very less, abysmally low. So no wonder we are sending it to 20 crore women Jan Dhan account. But really, in governance system also, we have smart cities. But from the angle of health, ma'am has given so many statistics. And ma'am's last slides also showed us the sign of a second wave, especially in Kerala, in Delhi, what's happening in Europe. And the concerns ma'am have really raised can prepare us towards this second wave of this pandemic, because prevention is better than cure. So how to mitigate the losses, I think ma'am has really highlighted from this diverse background. Ma'am, we have also done this telephonic survey on village makers, rural women. We have interviewed more than 5,000 women across India, and that was a time use survey. From there also many things have come up, and each hours we have recorded with more than 100 students. So many things are coming there also, and in this new digital age, many challenges. Ma'am is really highlighting that even the whole pedagogy and everything is getting affected. Ma'am, what in your view, what do you think that what should be the way ahead, especially keeping in the view the second wave, and how to mitigate the risk, especially when we know the areas of our threat, be it anemia or be it the hospitalization, nurses, Anganwadi, and many things, ma'am, you have touched upon. So what we can quickly learn and move in that direction for government, but also for communities and people at large. Yes, ma'am. Indu sir, do you want to add anything?
No, I just to that, I just want to, I think this friend has further written that thank you, Professor Sanghamitra. It reminds me of a response of what is now called ACEs, Adverse Childhood Effects, which would include how differently boys and girls are treated, discrimination or violence, and how this already affects a girl child's health. So it isn't just later life health affected by external factors, but the way a girl child is treated in childhood, affecting her long-term health as a child, teen, and adult then. Even her mental health factors like trauma or stress, and it appears care is so essential to ensure health and access to resources stemming from care. I totally agree, as Professor Sanghamitra mentioned, access to resources is crucial. How do we imagine a politics of care so young children are doing better on ACEs access is something I'm thinking about. And then she says, thank you everyone, and thank you Professor Kelko for your insights, experience, and sharing too. They resonate with me too about how there is difference in how girl children are treated in comparison to boy children in patriarchal setups. Yeah, Professor, over to you. Professor Sanghamitra, over to you. Yeah.
Thank you so much, Dr. Singh. Arjun, you've put up a very pertinent question. The first thing to your in the response to your query, I would say that the kind of fear which has got generated, we have to overcome that, because fear is not going to take us anywhere. And I say this very, very crucially also because, see, at this stage when the second wave is already knocking at the door, the community transmission of COVID-19 has already taken place. So if community transmission has already taken place, it's now like any other cough and cold which we have been experiencing for a very long time, except for the fact that infectivity here is much higher. That's the only difference, right? On the contrary, fatality is so much lower also. So the kind of fear which we have kind of been laden with, the moment you test positive, you believe you're gone, which is not the case. Infectivity is certainly high, but there are ways to take care of infectivity. And that's the point I was making, that it's more than roughly, I mean, if I have to quantify, about 92-93% will be able to, be dealt with without hospitalization. It's about 7-8% which needs hospitalization, and about 3-4 which needs critical care. So if that's where we are disaggregating this, why are we panicking? We're panicking perhaps the way we've had to deal with the guidelines, the way we've had many compulsive forms of, every day. I'm sure if I mean, we've done some kind of analysis of the guidelines. In a day, there was a stretch of about 10 to 12 guidelines coming from the ministry, from the state government, from local governments, etc., etc. So to me, that is important to be kind of done away with. And for that, we really need some kind of, very stark campaigning over and above the kind of campaigning which is being done to say, put mask and do this. And put mask, why, is not there. You're only being told to do certain things. Put mask for, yes, in today's Delhi, I'm sure we probably will want to put masks to protect ourselves from pollution. As much as perhaps even if we are not in the proximity of the individual. So that's one thing I think we need to overcome, the fear that we have kind of gotten on with. The other is, you very rightly say, when it comes to the subordinate level workers, the grassroots level frontier workers like ashas and ANMs, etc., who have to go into the community to tackle the contacts, etc. For them, it's important to bring on board the fact that they have all distance which is being maintained, and I refuse to call it social distancing. I'd rather call it disease distancing. And the sanitize the kit for their personal hygiene and sanitization is really important. I mean, that's more of a logistic kind of a thing. But overcoming the fear is extremely important for them too, because they are the contact into the community, which are also therefore sharing with the community that, look, this is nothing that you have to be, phobic about. It is there for sure. You have to take precautions, but not get, panicked about it. So I would probably put these two things as very important for us as members of the community. And from here, perhaps then the state has to take a call in revisiting the ways guidelines have been worded and phrased, etc. If I have been tested positive, what is the need that a policeman should come and take me to the quarantine center? Right. So somehow, and those are the stigmatization which has happened to the COVID-19 for me to have contracted, and therefore I will not want the state to know about it. So instead of allowing me that kind of space wherein I would come forward to take support from the state, I have actually come back into my shell, and I don't want to say that I'm COVID positive. Right? And we have stories of, I think it was Kottayam, where these Air Force, these Air India pilots housing society, they were asked to move out of the house because they were the ones who were flying in these flights, bringing in people from countries outside. So I mean, so that's the kind of fear and stigma associated with it. So I would want to say these are the two.
Yes, especially this problem of law and order becomes very much in hinterland. So people are especially talking about it, being open. Many of the places where it has spread, people have really been quiet, as if stigma or something of that sort. I think that is leading to more pockets where it is spreading fast. Again, I see a very direct link of education there, that at which level it is going. And I think the education of women of almost half the population becomes very important, because they have a lot of role in it, also for family and taking everything together, especially when the panic and this mode is coming. So nonetheless, I think Indu sir, we can wrap, or you can have, if you want to add anything.
No, I think I just want to further, I think, say that when the Ministry of Home is run by the IPC, then the police take charge of everything, So this way the problem is in the country today. And thank you for your fascinating, presentation. As Professor Govind mentioned, it's very comprehensive, and you touched almost all the areas. And so thank you and congratulations for this excellent presentation. And I think we'll share the recordings and everything with others also who couldn't come today. And thank you, Dr. Sanghamitra, Sheel, Acharya. It was fascinating, and we'll have more discussions within future also.
We really learned a new word, disease distancing.
Absolutely. Absolutely.
Very, very good word.
Yes, absolutely.
Thank you. Thank you so much.
Zindabad. Thank you. Zindabad.
Have a nice day.
Arjun, I'll share the slides with you in the mail, okay?
Yes, we will upload it and share.
Thanks a lot. Thank you.
Thank you so much. Thank you.
Thank you.